the thing with cancer rehab and this field in general, it's still so far behind that the community, the clinical community, the medical community isn't necessarily fully sold on it. And the other part is like, to be fair, the main job of any sort of oncology professional is to get the tumor out of your body. So there is a perspective that while it's important that they see like these changes that happen to the body, a lot of the perspective is like it's collateral damage. You know what I mean? Like it kind of take a little bit of loss of muscle and strength if we're making you free of the disease. All of which is to say that like so much of my job also involves engagement with clinicians and hospitals and going to tumor board meetings to make sure that we have a presence, because it's one of those things like out of sight, out of mind. And it's the same for kind of any supportive care, whether that's psychology, nutrition, even social work and stuff like that. In the States in particular, the financial burden of treatment is insane. So the primary purpose of hospitals here is like get the tumor out of your body. And then secondary to that is like, oh, listen, all these other things can be helpful. So I've learned a lot early in my career of how resilient you have to be and how determined you have to be to just kind of keep putting your foot in the door and giving yourself a place at the table to be able to give access to people who need it.
Is that incredibly frustrating for you? Are you at the point where you just understand the system, it is what it is?
That's exactly what my trajectory was. My early career, the frustration was insane. I just couldn't understand like how beneficial it can be and how many people are ignoring it. Well, ignoring it, so to speak.
Yeah.
And I was just so frustrated of like, everyone should be getting this, or at least be recommended to talk to someone like us who can help support them and decide what's safe and what's right and whatever. The more I've gotten experience in the medical field at large and see like, right, hold on a minute, you've got an oncologist who has 40 patients in a day. So on average, they've got anywhere from 7 to 12 minutes with the patient. And in that 7 to 12 minutes, they've got to talk about if their cancer has progressed or not, explain what treatments they're getting, explain what those treatments mean, what they're going to do to their body, how much it's going to cost, their schedule. The last thing on their mind is going, oh, and by the way, you should try to do a bit of exercise. So the more experience I've gotten, like it's less frustration with the community and more a desire and determination to figure out how we can create space for ourselves there, which is to say that like we don't need oncologists to be the ones prescribing exercise. We just need them to act as champions. And if we can change, because this is also like you have to work institution by institution because there's so many different cultures and readiness and all the rest of it. You have to try and change the culture of that institution so that it's an opt-out rather than opt-in, such that this is just a part of your care. You meet with your radiation oncologist, you meet with a medical oncologist, you meet with an exercise physiologist, and you have to decide that you don't want to do them.
Yeah, so like you're saying, right now it's a extra, we'll say, or like a supplement, but you want it to be like severely ingrained in terms of the treatment process.
Yeah, exactly. It would be an afterthought. It's much more rare to find an oncologist who would outwardly say that is not appropriate. It's more common to find people who say, this is brilliant. I think it's a great initiative. I'm too busy. I don't have time and our infrastructure isn't set up for this. So like if you can make it work and don't impact their clinic flow, go for it. That's kind of a lot of what you try to do. I did my postdoc over in Australia and got some really good training. And I thought I was kind of like building this reputation or evidence in the field or whatever. And then I came to South Carolina, and rightfully so, no one knew who I was or what I was doing. So there was no trust, there was no rapport, there was no relationship. So I'm here 4 years now, and it's taken me to go to like 2-ish to really build like solid community connections in the oncology community, to really build their trust and make sure that they know that I'm taking care of their patients and that our lab and our staff are trained well enough to understand what the cancer experience is.
I'm not really surprised, but it is amazing that it has to be done area by area. And like you have to almost go out and fight your corner in a way to promote something that you would think would be, in my opinion, just so obvious.
Yeah, it's kind of like both. You need the bottom up, which is like all of us going to individual communities, and we need to upskill workers and all the rest of it. At least in the US, there's definitely a top-down approach that's coming, which is a lot of researchers in health policy are trying to generate sufficient evidence that outside of like, can exercise help you tolerate treatment? Can it also improve treatment efficacy or effectiveness? Can it influence mortality rates? Can it influence survival? So that builds a body of evidence so that in this country, at least, insurance will pay for it. And then it might be mandated across the country. So I think having both prongs will be helpful of like top down, it's mandated, bottom up, you have people who are skilled enough to do it. But that's specific to the US. So Australia, for example, their clinical exercise physiology infrastructure is incredible. Exercise physiologists in Australia are on par with physical therapists. They're kind of deemed the same respect, whereas like in the US and Ireland, it's not really that way. So when you get any sort of chronic disease in Australia, you get like 5 free sessions with an exercise physiologist who can like look
Wow.
after you. Yeah. And then Germany has 50. So Germany's infrastructure, you get 50 free sessions. So I've been lucky to be able to like been exposed to different countries to see kind of like what models might be advantageous. The US is a profit-based healthcare system, so it's difficult to make exercise profitable, especially in the clinical space. So we're trying to drive the policy so that insurance reimbursement will cover a lot of it.
I think just building off that, can you explain how exercise can impact the outcome of cancer treatments?
Yeah, I guess stepping back a bigger picture, like I've been doing this for a while and you're always getting the question of like, why should they? And when I talk about it, all I have to do is list all the side effects and all the impact of treatments. And then it basically becomes of like, well, tell me why they shouldn't. Because based on the type of tumor you have, the stage of tumor, which will influence the type of treatments, the dose of treatments, the sequence of treatments, and the combination of treatments. So like solid tumors, for example, almost everyone gets surgery. So inherently you will have some sort of tissue change, maybe some range of motion difficulties around that tissue or around the surgical site, some weakness around that surgical site. And then let's say you get that paired with chemotherapy, and chemotherapy there's hundreds of different chemotherapy agents and all given for different reasons, but they're generally systemic. So they're flushed throughout the body. And that's what happens when you see like people losing their hair and their taste changes and skin and nails and stuff kind of gets a bit out of whack. They're the visual changes, but the really profound changes from chemotherapy are things like cardiovascular damage. So damage to the heart and the structure and function of the heart. You could have pulmonary damage, so damage to the pulmonary system and the lungs. And muscle weakness happens very commonly, where you have the chemo can actually signal the muscle to start to waste away. Then you lose muscle strength, you lose bone health, you gain fat mass. And so like you pair up all these things and go, it's no wonder people's bodies are destroyed. And there's no pharmacological agent that's going to combat them as effectively as exercise. So we know exercise is really powerful at improving cardiovascular health. It's really powerful at improving muscular strength and body composition and improving muscle weakness and stuff like that. So you start to pair all those together and go, it's a no-brainer. And the irony is generally the worse your trajectory is going to be, the more beneficial exercise can be if you start it early enough. Because one of the most challenging things about exercise, particularly during treatment, is it's not that you're going to see massive improvements. It's not the goal of exercise during treatment. The goal of exercise during treatment is, can we keep you looking and feeling the exact same 6 months from now? Because what happens otherwise is you do see gains of fat mass, loss of muscle mass, you start to see frailty, nausea, weakness, all this type of stuff. So if we can keep you where you're at 6 months from now, you're in a great spot. You've gone through this really traumatic period. The challenge to that is if I asked anyone to go, hey, listen, you're going to come to the gym 3 days a week. You're going to do that for 6 months. It's going to be really, really hard. And you're not going to look or feel any different. They're going to be like, there's no way I'm signing up for that. The really challenging part of that is more so the behavioral aspect of trying to keep people engaged. There is some really cool ongoing research that I hesitate to say because we don't really know how it's going to shake out, but there's some early biological work that is suggesting that particularly cardiovascular exercise, if you train animals during chemotherapy receipt, cardiovascular training can normalize some of the vasculature, so some of the vessels that help deliver the drug, which allows the drug to get to more parts of the tumor and allows the drugs to be more effective. So that's kind of been in our field for about 15-ish years of like this kind of idea of like, maybe you can also increase the delivery, enhance the effectiveness of chemo agents in particular. I hesitate to say that because there's some ongoing trials now that will be finished up in a few years and we'll probably have some more answers to that. But at least that's the idea of not just like, can we minimize symptomology, but maybe can we make you more robust and improve the effectiveness of the treatments themselves?
That's an interesting kind of concept in itself. And I agree what you said when you mentioned about it's really difficult to get someone to engage in this exercise and telling them basically like, it sounds like a damage limitation thing. Like you're not going to see any quote unquote gains that most people might associate with exercise or the gym. Like it's doing such an important part in terms of like, is there any studies to show like the mortality decrease rate or anything specific like that?
Yeah, generally there's some fairly decent, like large epidemiological evidence. Now, it's not randomized controlled trials. There's a couple of those that are wrapping up at the minute that are larger in size. But generally, the epidemiological evidence follows that the more active you are consistently throughout life, the lower your risk of cancer-related and all-cause mortality. So there's definitely some strong evidence in support of lifestyle behaviors and maintaining that. And the other way I'd conceptualize it is think about your grandparents or your parents, depending on what age you are, and like what happens to them once they age. Heart health is important and it's great to get up to the healthy age, so to speak. But what happens is people stop doing any sort of strength training. So that means then it's hard to get out of the chair. Like you see the granddad rocking chair, like they have to tip over if they fall back in the chair and then they're stuck for the night. Or carrying shopping in and out of the car, or you're carrying washing up a stairs and the dog runs out in front of you and you slip and fall. Like those are all really high risk factors that mean it no longer becomes safe for you to live on your own. And so that means then you're going into assisted living. And like that, once you kind of reach that threshold of disability, meaning it's very difficult for you to maintain your life independently, that's a spiral that goes pretty quickly. So what happens in the context of cancer is all these changes happen to your body. You gain fat mass, you lose muscle mass, you lose bone health. The other part that happens with that is like peripheral neuropathy, for example, is very common with chemo agents, and it causes a lot of changes to the nervous system in the extremities and hands and feet. So you got a lot of grip issues, you got a lot of balance issues. So now imagine like you've gone through an experience and you come out the other end, you have less balance, you're weaker, your stability's off, your muscle strength isn't there. So now when you trip over, walking through the house over your hoof or whatever, you don't have the ability to put your foot out quickly, stop your fall, stand up and regain your balance. And then because your bones are weaker from the treatments, that fall that happens now turns into a fracture. The epidemiological evidence kind of generally supports that. But on an individual level, that's the experience of like, we need to keep people out of that disability threshold. So we see across cancer treatments, we see this dip, the treatment suppression, inactivity that goes with it. There's a lot of depression and anxiety and fear that comes with cancer that makes it difficult to participate in exercise. I've never seen anyone spontaneously start to exercise when they get cancer. And I've never seen anyone kind of who has been fit not struggle to stay fit and kind of get back to their high level fitness after. So we basically treat people, get the tumor out of their body, and then leave them in a really vulnerable condition. They might ring a bell and say you're good from cancer, but then they're in this vulnerable condition for the rest of their life. That's where it's really important that we come in and really help them regain their fitness and life.
Yeah, you're coming in at a point when I'd say motivation is at an all-time low, if not non-existent as well. And you're trying to ingrain these habits, which are difficult to ingrain, like if you had no situation or nothing going on in your life as well. So it's definitely a tough situation for you to come in, but it's also really important for we'd say the patient or the person as well to engage in something like that.
Yeah, absolutely.
I think everyone has a story similar to what you mentioned. Like I was just thinking of my grandmother when you were talking. She grew up and lived in my home house, and it was like the classic. She was in, we'll say, semi-care with us and then fell, broke her hip, and like that was quality of life plummeted at that point. I think that's so common, like the difference between that happening versus having enough strength to like be able to, when you're falling, like put your hand out and not suffer that broken hip. Like that can make all the difference too to people.
Exactly, yeah.